Buenas tardes. A continuación.
Good afternoon. The next speaker is going to be Dr. Blanca Cabezas. She's a doctor of stomatology with a master's degree in periodontology. She's going to speak about the relationship between tobacco and oral cancer and the attitude of an odontologist facing a patient who smokes.
Buenas tardes.
Good afternoon. For the next few minutes, we're going to try to learn what are the actions that we should have at the clinical practice. If we have a smoker patient, we have to explain what tobacco addiction is on the one hand. Secondly, we have to explain the different types of intervention that we have to help a patient to quit smoking. And last but not least, the different types of treatments that exist today. What is tobacco addiction? In 1998, the WHO defines smoking as a chronic addictive disease. And from then onwards, the grounds were established to consider tobacco as an addictive substance. Nowadays, tobacco is considered to be one of the substances with the greatest capacity to lead to addiction. Most people who smoke wish to give up, to quit. 60% have tried sometime. Nevertheless, at the end of the year, only between 3 to 5% of those who try are successful. This makes smoking a complex problem and hard to solve if we don't have the right treatment and assistance. A change of habit, that's what we endeavor when we want patients to quit smoking, is not a spot issue. It's a long process with several stages. This process, that is usually long, may be accelerated if we have a health practitioner who is trained. The stages were described by Prochaska and Di Clemente in 1982. They are the pre-consideration, the consideration, the preparation, the action, and last, the maintenance stage. In the pre-consideration stage, the patient is not aware that smoking is a problem and does not wish to quit smoking. If we ask the patient, in the next 6 months, are you willing to quit? The patient would say no. The next stage is the consideration when the smoker acknowledges that smoking has negative consequences for health and would be willing to try to quit smoking in the next 6 months. Then the patient may start the preparation stage when the smoker is willing to seriously try to quit. Most importantly, this sets a date, the patient has to set a date in the next 30 days to quit smoking. And so the patient goes to the action stage. During this stage, the patient no longer smokes. And this stage goes up until 6 months after having quit smoking. And then we enter the maintenance stage 6 months after quitting smoking up until 1 year. A year after having quitting smoking, we consider a person to be an ex-smoker. However, we have to bear in mind that a lot of people fall back into smoking. In many cases, several attempts are needed to change the behavior. We have to remember that smoking is a disease. It's a chronic disease with remission and relapse. And so we have to have continuous attention to our patient up until we achieve the final change. We must consider success not only for the person to quit smoking, but any changes in the stages in the whole process of quitting smoking. To sum it up, I'll try to explain it with this chart. The stages are, to start with, pre-consideration, where the patient is not aware that tobacco is a problem and does not think about quitting in the short or middle term. Then the patient may start considering to give up in the next few months. Then the preparation stage, when the patient is willing to make a serious attempt to quit smoking within the next 30 days. The step from one stage to another may take longer or shorter, and the patient may do it on his or her own or with the assistance of a health professional. Once the patient quits smoking, the patient is in the action stage. 6 months later, in the maintenance stage, up until 1 year later. From action and from maintenance, there may be a relapse. The relapses are frequent. In fact, it's yet another stage within the whole process. And this should not discourage neither the smoker nor the health professional. From relapse, the patient may start to get in the pre-consideration or may go on to consideration, preparation. And this is what we mean when we speak about a spiral succession. It's also important to look into which stage a smoker is in. The attitude that we have with a smoker is determined precisely by which stage the smoker is in. There is a test that we propose, that of Prochaska, because it's simple and efficient. We will ask the patient, do you smoke? If the patient does not smoke, we have to learn for how long. The patient may have never smoked, so it's a non-smoker. If the patient has quit smoking a year ago or more, it's an ex-smoker. If the patient is between 6 months to a year, it's in the maintenance phase, and less than 6 months action. If the patient is a smoker, we'll ask the patient whether he or she wishes to quit smoking. If it's not within the next 6 months, it's pre-consideration. If it's yes within the 6 months, it's consideration. And if the patient is willing to quit within the next month, the patient is in the preparation stage. So that's the end of tobacco addiction. Now let's see what types of intervention we have to help smokers quit. 6, the health advice that is promoted for change. Then we have the brief intervention, the intensive intervention, specialized treatment, and community interventions, and the use of communication technologies. The health advice is done by the health professional at a normal visit. In the professional's normal words, this will last between 1 to 3 minutes. Its efficiency is absolutely certain. The more the advice, the more the likelihood for the patient to quit smoking if we compare it to not doing anything. The more intensive the intervention, the greater the efficiency obtained. The goal of health advice is threefold. First, to learn if the patient smokes, then analyze if the patient wishes to quit, and then third, to provide advice for quitting. This is the intervention of the 5 A's in Spanish. This is recommended by the U.S. Health Administration. There are 2 A's missing here. We shall see them later on. So we have to learn if the patient smokes. What do we mean by this? The health professional must always ask every patient over the age of 10 if he or she smokes and record this in the clinical record. We cannot help a patient quit smoking if we don't know if the patient smokes. And 15% of dentists in Spain do not ask patients if they smoke. And every 2 years, we have to ask again if the patient is smoking. If the patient is not smoking, we will congratulate the patient and encourage the patient not to smoke. If the patient is smoking, we go on to the next goal. That is analyzing in which stage of change is the patient. So we apply Prochaska's questionnaire. I remind you, ask the patient whether the patient is willing to quit within the next 6 months or within the next month, to see whether the patient is in pre-consideration, consideration, or preparation. And the last part of the health advice is to advise the patient to quit smoking. Our advice must be brief, firm, positive, and tailored to the individual, to the patient, and to the stage of change in which the patient is. And we must provide information about the consequences of continuing to smoke, always highlighting the benefits of quitting smoking. So let's be positive. Secondly, we must ask about the reasons that would lead a smoker to quit. Sometimes it might be the patient's health or the health of the smoker's family. And we can take this reason, the reason for the medical consultation, to also advise about how good it would be for the patient to quit. and we must increase the self-confidence of the patient to achieve the goal of the patient quitting smoking. In order to facilitate all this motivation, it can be tough. You have in the magazine, in the journal, a list of reasons that can be tailored to the patient's characteristics to make the patient reflect on how good it is to quit smoking and how bad it is to not quit smoking. So the conclusion of the health advice is that all health professionals should know and apply this health advice regardless of the level at which the health professional is involved. Besides, it's useful to deliver self-help handbooks for the patient to take home and read and continue to reflect. With this, we conclude the health advice. We go to the next intervention, the brief intervention. It is a little more complex. The brief intervention is defined by the concept of time. This is an intervention of less than 10 minutes made by a health professional in healthcare. By healthcare, in a healthcare environment, I mean it's not necessarily an ordinary consultation as opposed to the health advice. This can be a normal consultation or a programmed consultation. Another difference is the time of this intervention. It's less than 10 minutes when before it was less than 3 minutes. Another important difference is that a brief intervention is not addressed to all smokers, only those who are in the preparation stage. In other words, patients who are willing to make a serious effort to quit smoking within the next 30 days. And the last difference between the brief intervention and the health advice is that it's not necessary to be made by all the health professionals, but only those who feel capacitated to do it. The goal of the brief intervention is twofold. Here we have the two A's that we were missing before. On the one hand, help the patient to quit or agree to a follow-up visit. What do we mean by aiding or helping the patient who wishes to quit? The professional must help the patient if the patient decides to quit smoking. The patient must be given some minutes without any rush, and we may also give the patient a further appointment. We have to make the smoker learn about his or her addiction and to see if they have a degree of motivation. This can be assessed with the Fagerstrom and Richmond tests that are also there in the article. It's very important for the smoker to know what are the features of the addiction, because with better knowledge of the addiction, the patient will have tools to overcome difficult situations, increase self-confidence, seek help in the environment, and draft a plan to quit smoking. This plan must include the following actions. Set a date within the next 4 weeks. D-Day will be the day I'll quit smoking. The patient must be also given some recommendations for the days prior to D-Day. The patient must also have clear recommendations for the first days after having quit. And we provide the patient with informational material and a practical guidebook to quit smoking. The article has some recommendations that the patient may be given to make our task easier. Besides, every patient who is interested in quitting smoking must receive some sort of pharmacological treatment. Using these drugs, the syndrome of abstinence is decreased and the probability of success increased. We recommend drugs for those who have a high dependency or to smokers who smoke more than 15 cigarettes per day, or those who smoke in the first half hour after getting out of bed in the morning. The drug can also be used for those who have tried unsuccessfully for several times, especially have started smoking again in the next few weeks after quitting. Then we have to plan the follow-up visits. This is important to follow up on progress, reinforce motivation, and control the drug treatment. Follow-up visits are recommended in the first, second week, first month, second month, third month, and 1 year after. These visits may also be used or may be carried out when the patient has another consultation for another reason. Now we'll speak of the intensive intervention. It's a clinical meeting between a patient and a trained coach or advisor with sufficient time to carry it out. It has the same activities and goals than the brief intervention. However, the differences are, first, the time devoted to the patient. In the previous case, 3 or less visits, less than 10 minutes. Now it's 4 or more sessions of more than 10 minutes. It's usually 10 visits, about 15 minutes each. The frequency will be tailored to the characteristics of each patient. The second difference is this intervention will be applied to those patients for whom the brief intervention was unsuccessful. And finally, it's the type of consultation. In this case, they are all medical appointments. In the previous cases, they could be normal visits or appointments. In this case, they're appointments. This intervention was designed to make the consultation by healthcare teams under the supervision of a doctor who is controlling the drug treatment. Now I'll speak of the specialized treatment, whose aim is to promote patients quitting when the intensive intervention has failed, or in such patients that urgently need to quit smoking. It is addressed to individuals with one or more of the following conditions: a high degree of dependency and repeated failure in consolidating abstinence, patients with some sort of psychiatric disorder, or patients whom by smoking will endanger their health if they've just had an infarction, if they're going to get surgery, or pregnant women. The differences with the intensive treatment are, first, the type of population to whom this is addressed, as we have seen, and secondly, the qualification needed by the professionals. Previously it was a doctor and a nurse. Now we need a doctor, a nurse, and a psychologist that is trained in smoking. And this is also a very intensive treatment. Remember that the greater the intervention, the greater the efficiency or the efficacy in the outcome of the treatment. We said that there were 6 types of intervention that we have to help patients quit smoking. I would describe the last 2 because they are out of our scope. And although specialized treatment is not necessarily within our scope, I did want to at least mention it to recognize in which circumstances a patient will be needing this treatment, so we will refer the patient to where the patient may be properly treated. To sum up, all health professionals must know and put into practice the health advice. This has to be always done for all patients, regardless of what the patient has come to the consultation for. It is recommendable for dentists to be familiarized with a brief intervention, as by implementing it, we will increase the likelihood for patients to quit smoking. However, it's not necessary for the dentist to know in depth all the different types of treatments and to perform them at the clinical practice, although this would be desirable. Our role may be limited to refer the patient to a smoking unit once the patient is in the preparation stage, as you refer a patient to the hematologist to control oral anticoagulants or whatever other referral. We believe that the dental consultation has the necessary conditions to also treat smokers. If a patient's smoking condition is not treated, after the advice, the patient must be given some brochure with information on how to quit smoking to help the patient up until the patient goes to some sort of smoker's unit or stop smoking unit. I'll recap the types of intervention before speaking of treatment. In this summary, we face a patient. The first we have to do is ask whether the patient smokes. The patient may reply no. So we'll see if it's a non-smoker, in which case we will encourage the patient to not smoke ever, and we shall ask the patient again after 2 years. If the patient is an ex-smoker, we'll congratulate the patient and inquire every 2 years. If the patient is an active smoker, we'll ask the patient if he or she wishes to actively quit. If it's no, it's pre-consideration. If it's yes in the next 6 months, it's consideration. And if it's yes in the next month, it's preparation stage. Every patient in pre-consideration or consideration stage must go back home with the health advice as a takeaway message. Patients in the preparation stage, we can either treat them or give them an appointment to treatment or refer them to have brief or specialized treatment. In the meantime, we have the intensive treatment, the intensive intervention that is only for the cases in which the brief intervention has failed. Now let's speak of treatments. 3 types: drugs, psychological treatment, and others. Pharmacological treatments may be first line or second line. First line drugs, for their safety and efficacy, are substitutive therapy with nicotine, bupropion hydrochloride, that is sold as Zintabac, and varenicline, that is sold as Champix. And the second line for the tolerance problems are nortriptyline and clonidine, or Dine. First choice drugs may be used by every smoker patient who wishes to quit smoking unless there is some contraindication preventing its use. If it's a woman who is pregnant or lactating, teenagers, or those who smoke less than 10 cigarettes per day. Let's speak about the nicotine substitution therapy. It consists of administering nicotine to the smoker in a different way, not by smoking, in a sufficient amount to avoid the effects of the abstinence syndrome, but not enough to create dependency. Nicotine may be transmitted by the skin with patches, or orally with chewing gum, sweets, or pills, or intranasally with a spray. In Spain, we only have chewing gums, patches, and pills that you have to suck on. The nicotine release through chewing gum and pills is very quick. This is very useful to control the craving, the intensive desire to smoke. However, the patches release nicotine very slowly, and this helps control the abstinence syndrome. The substitutive therapy is very efficient. However, the efficiency increases if it is adapted to the individual patient, and of course accompanied by some sort of support intervention. Better results are achieved if we have the combined therapy of slow and fast release therapies, such as chewing gum, together with patches. Bupropion is the first non-nicotinical medication that has been proven to be efficient in treating smoking conditions. It's an antidepressant that inhibits the reuptake of noradrenaline and dopamine. Increasing dopamine, it reduces craving, and with increased noradrenaline, it minimizes the effect of the abstinence syndrome, such as anxiety or irritability. Bupropion is efficient to quit smoking, provided that it is used as a coadjuvant of the brief intervention, the intensive intervention, or the specialized treatment. It's so efficient that it doubles the success rate compared to placebo, but it's important to bear in mind that it's not a question of just prescribing a drug. Treating smoking is a complicated issue, as we have said, and in doing so, we have to approach it from different viewpoints. Drugs are a powerful tool for therapy, but they are useless without another assistance, and normal therapy will not be fully achieved unless it is accompanied by some sort of support drug. We may combine bupropion with nicotine substitute therapy, though there are no studies that say that this is more efficient than when administered individually. The second first-line drug that we have is varenicline. It is specifically designed to help smokers quit. In May 2006, the U.S. drug, it's probably the FDA, approved the drug, and in Spain it was approved in the year 2007. It's an agonist for some nicotinical receptors with a dual or a twofold effect. It increases the concentration of dopamine, so it diminishes craving. This is the agonist effect of the drug. On the other hand, since it does not help nicotine bind to its receptors, it decreases the pleasure that the patient feels when smoking. It's the antagonist effect. The latter, the antagonist effect, the lack of pleasure when smoking, can be very useful to prevent relapses. Varenicline triples the likelihood of abstinence in the long term compared to placebo, and it is more efficient than bupropion. However, they must always be accompanied by some sort of support therapy. I can speak about the second-line treatments. These are drugs that have been proven to be efficient for smoking, but are less frequently used because of the side effects. Besides, the Directorate General for Pharmacy of the Spanish Ministry of Health has not approved its use to treat smoker conditions. There are two. Clonidine, it's a noradrenergical alpha-2 agonist, and it's used especially for high blood pressure. It has been efficient in the use of smoking. It doubles the effects compared to placebo. And nortriptyline, it's a tricyclical antidepressant useful also for quitting smoking. It also doubles the abstinence rate compared to placebo. Once having spoken of the pharmacological treatment, let's speak of the psychological treatments. When are they indicated? I won't describe the details. Psychological treatment must be offered to all patients who have received a specialized treatment where there has been a psychologist involved. Patients with a high degree of dependency, with many relapses, pregnant women, patients with psychiatric disorders, or patients for whom continuing may be very, very dangerous for their health. And we have these other types of treatments. There are many, many of them. Acupuncture, digital puncture, hypnosis, electrostimulation, laser, whatnot. All that is clear about these other treatments is that the reviewed studies state that they do not have better results than any other placebos. That's all. Thank you very much for your attention.